All right. Well, good afternoon, everyone. We're right at noon or 12:01 here in Washington, D.C. I'm hoping everybody's having a good morning today. I'd like to welcome our guest, and we'll start with Mia Keys, who's obviously been with us for a while and leading these great webinars and educating everyone. And instead of me introducing folks, I'm going to go ahead and turn it over to Mia.
Well, good afternoon, everybody. I'm really excited for today's conversation. We have a fantastic panel with us, but first and foremost, thank you very much to the NMQF family for always providing this platform for just digging into conversations that are related to COVID, but then also with respect to, especially today's subject, things that have been with us, issues that have been with us for quite an enduring period of time. And we're really looking to dig into the topic of obesity. And so today we have with us, to help us to do that, we have Dr. Fatima Cody Stanford, who joins us today from Massachusetts General Hospital, where she's also a professor and practices at Harvard Medical School, and is one of the first fellowship-trained obesity medicine physicians in the world. And if you've read anything about her bio, you know that she's quite committed to the cause, not just within the classroom and not just within practice, but from a policy standpoint. And I'm really honored that she's joining us here today. Welcome to you, Dr. Cody Stanford. And we also have with us Nikki Massey, who joins us as the chair of the Inclusivity and Diversity Task Force of the Obesity Action Coalition, which is more than a 70,000 member strong 501c3. And she's going to talk to us today about some of the work that they're doing, especially their core focus areas with respect to raising awareness and overall just improving access to prevention and treatment of obesity from an evidence-based perspective. And overall, we just have, really very powerful women who are going to help lead this conversation. And I hope that beyond even the clinical stuff, some of the political stuff, we're going to talk about how obesity and really the plight of obesity, the epidemic of pandemic really, is so also very sensitive to Black America and especially to Black women. So with that, I welcome you, Nikki. I welcome you, Fatima. Thank you so very much for joining us. And before we get started, why don't you just tell the audience how you're doing? How's everyone doing today?
Well, Mia, thanks so much for having us. I think this is, first of all, a strong panel of Black women. I want to just acknowledge that greatness. So hashtag Black Girl Magic there. I'm doing fine. Actually, the weather in Boston is quite lovely today. So I've been out on a bike ride, still perspirating, as you guys can't see me. Those people that are watching online can't quite see, but let me tell you, I've gotten that activity for the day. So I'm excited, exhilarated, and really enthusiastic about this conversation that we'll have this morning or this afternoon, depending upon where you are.
Thanks for having me today. I am doing well too. I am working from home, which I have been since the start of the pandemic. The last few weeks have been dedicated to adjusting my two college-age daughters to the realities of how they're going to be studying. I have one that went back to campus, so we're watching that situation very closely. My youngest, who would have entered her freshman year at Howard University, actually is studying from home. They converted to online learning, and so just getting adjusted to that and, managing my work life balance and everything. But I am very, very excited to be here. And I am very excited to be here with Dr. Stanford and the whole panel. So thank you for having me so much.
Well, we're equally excited to have you all. And clearly the chat is buzzing with all kinds of activity. Keep the conversation going. Keep feedback going in the chat. With your specific questions, audience members, put those in the Q&A box so that way we can see them easily. But otherwise, keep it going. I'm wondering, Nikki and Fatima, can you just level set with us? Talk to us exactly, based on the work that you do and the science and also anecdotally, what exactly is obesity? How does it express itself? And particularly, how does it express itself within the Black community pertaining to Black women especially?
So I'm going to start with the science part. Nikki, I'll have you take over because I really wanted you to talk about what it's like to be an advocate and on the patient side. So people, when they hear that I'm an obesity medicine physician, I can tell you that there are a lot of startled faces. They're like, what? You did a what? You did a fellowship in what? And what I want people to know when they're looking at this today is that obesity is actually a disease process. It's not just what you look like. It's that's how we've really looked at it from a perspective of aesthetics. This is not an aesthetic disease. I do not look at my patients and decide this person looks different or better or whatever than another person. It's a disease process. And really it's important to know that the part of the body that actually regulates weight is actually the brain. And a lot of people think it's all around like willpower, what someone does or does not do really, helps one determine what someone's weight status is. But the brain, and there's a particular part of the brain called the hypothalamus that actually sends signals to your body to tell you not only how much to eat, but how much to store. And it's a really complex system within the brain. There's a really complex system in the brain that signals between the brain and the gut that then governs food intake. Now, people then always ask me, so is it just science? No, it's not just science. It's influenced by things such as our environment, right? Things like food quality, our physical activity, our stress, racism, which can lead to stress. So we're going to get into that conversation today. Our genetics are hugely important. And I always like to bring up this point in any conversation that I have about obesity and the genetic heritability of obesity. So it's important for us to recognize that weight is more heritable than height. And so I like to say that again so people can get it. Weight is more heritable than height. What that means is if our parents have obesity, the disease, the likelihood that we indeed will have obesity ourselves is on the order of somewhere between 50 to 85%. So it's not just about what we're feeding our kids or what activity they're doing or whether they're getting enough sleep or stress or these types of factors. A lot of it is how we are transmitting it from generation to generation. And when we look at the prevalence of obesity in the United States, the group that tends to be disproportionately impacted, I would say the highest group is the group that you see on this call, Black women. And it's really quite disconcerting. When we're looking at the estimate, so the definition, and I'm putting definition in quotes because this is how the Centers for Disease Control and Prevention and the World Health Organization define obesity. It's classified only by body mass index, which takes into account just height and weight, and then determines if you are someone that has a normal weight status, if you have an overweight status, or if you have obesity, okay? So anything that's over 30 is considered to be someone that has obesity by this definition. And then there is mild, moderate, and severe obesity. So one that has a BMI from 30 to 34.9 based upon this calculation has mild obesity. Someone that has a BMI from 35 to 39.9 has moderate obesity. And then someone that has a BMI greater than or equal to 40 has severe obesity. And the reason why that has typically been classified that way is that the treatments that we would consider differ based upon the severity of the disease process. So we can decide, okay, if someone has severe obesity, we can use certain treatment strategies that we wouldn't use for someone that has overweight or has mild obesity, for example. So it gets into a lot of things. That the problem, and why I put that in quotes, this definition, is that just looking at height and weight doesn't give us much information about the body. We need to know where adipose is fat tissue, where that is actually distributed. And as Black women, we tend to carry more of that in the hip, buttock, and thigh region. So we tend to have a gynoid distribution of fat. What happens is when it's stored centrally around the abdominal region, central adiposity, which just means central fat deposition, that's when it becomes significantly problematic. So notice, it's not necessarily just about the weight, it's about where that weight is distributed that really can lead to worsening illness and disease. I'm going to stop there because I can get really scientific, but I want Nikki to, calm it down for us for just a moment.
Thanks. From the patient perspective, I'm glad you brought up some of the points that you did about the BMI and how it affects African American women, and especially, I think from my experience, just being told to eat half the food on my plate, to, all of these different experiences that I've had when I've tried to meaningfully approach my doctor, because in reality, I knew that I had a weight problem. At my highest weight, I was about 360 pounds. I knew that that needed to be addressed. And when I brought it up with the doctor, I didn't know what to expect to get back from my healthcare provider. Which was very disconcerting. It was also disconcerting on the patient side that a lot of people report, and this is one of the things that the Obesity Action Coalition keeps its eye on, is that, a lot of times you'll go to the doctor with a completely, different sort of, my toe hurts, my head hurts, I get headaches. And it's automatically attributed to weight without much guidance on how to address the weight. Number one, the original problem may or may not be directly related to weight. And then two is, if you're going to bring up weight, help me have a meaningful conversation. One of the things that got me looped into the OAC is their Your Weight Matters campaign, which is a resource that is online that can help folks to have that initial conversation with their primary care provider or whoever they're going to see about their weight. And I think that's a particularly helpful thing, because we all know about the BMI. The BMI is a little less than helpful though, because we tend to attribute sort of values to that. If you're over a certain number or you have a certain distinction that is quote unquote bad, versus under a certain distinction being good. And it's so important that you pointed out that the distribution of fat is as important as the BMI itself, and maybe even more so, because of the fact that there's been this ongoing debate in public society about whether or not somebody could have overweight or have obesity and still be healthy. And that's a debate that is ongoing. It's a debate especially that I feel like rages within the African American community, because I see us very well represented in like the healthy at any size and body positivity movements, which I think are all, sort of great movements. However, there's always been this sort of back and forth about, can you be a bigger person and still be healthy? So those mixed messages all sort of come together to create a lot of confusion for a person who's actually affected by obesity about, is this something that I really need to address? How do I address it? Being timid to address it with their doctor or primary care provider. And then when you get back confusing information, you have absolutely no idea what to do next. I would take that piece of paper and just go back to doing what I was doing, because I really didn't have much guidance. So that's how obesity has sort of manifested itself for me from the patient side.
You both brought up some really important points, and I want to tease them out. And I've just taken notes for myself so that we can hit them all. So Fatima, you were talking to us about well, I was listening to your language. You were saying have obesity, right? But usually in national conversation, the language is someone is obese, right? As opposed to saying someone has obesity, right? So talk to us about the significance of that language, please.
Absolutely. If anyone is listening and has ever heard me give a talk, they will know that I will get on my soapbox moment before I start any talk and talk about the language that we use when we're talking and working with patients that have obesity. Obese is a label, but obesity is a disease. And so when I give that label of obese, it's often inflammatory. It's met with significant resistance. It's as I'm talking bad to you. When I say a person has obesity, we acknowledge it for the disease it is, and then we begin to think about how we are going to navigate that. So if you listen to what Nikki said earlier, she said, I knew I had a weight problem, and she was met with a range of potential therapies, everything from like, you just need to cut your portion sizes in half, to here's a food pyramid. Really, unfortunately, very rudimentary, poor understanding of obesity as a disease. And so I like for us to make sure that we're giving respect to our patients, regardless of what their size is. I have patients that range upwards of almost 600 pounds. I don't treat those patients any differently than I'll treat those patients that are much leaner. I mean, they deserve respect as a human. I think we have to also think about the intersectionality of weight bias and stigma and race bias and stigma. Those are the two most common forms of stigma that exist here in the United States. And when we have the overlay of those two, you can imagine that can be very inflammatory and then will affect one's care within the setting. So if they come into my office and I'm saying, hey, I won't use those words. Actually, I can't use them. They make my heart palpitate. But if you were to say the words that you said, and then, or you're being told something or someone's snickering behind the counter as you weigh on the scale, you might not, even before you even get in to see me, the doc that maybe, you may feel like you have a great connection with, hopefully, right? You already feel like this place is not welcoming. So are you going to come back into that setting, or are you going to venture and try yet another doctor? Maybe you've been struggling with your weight since you were a child. And here is again and again, you're finding that you're facing resistance from the medical community about how to navigate this disease. What we do when for many people with the lack of knowledge. And so I published a large study that came out in the International Journal of Obesity, where I looked at the education of doctors and medical students, residents, fellows throughout the entire world for the last 15 years to see what are we being taught? Is any country doing a really great job? And I have some unfortunate news to report. There is no one country that really was the gold star. We can't say, wow, if you look at Kenya, they're doing an excellent job. Or wow, if we look at Switzerland, they're doing an excellent job. All countries throughout the world, despite the rise in prevalence of obesity, are doing a horrible job of educating doctors. They know just as much, unfortunately, about obesity as you do, unless they've sought additional qualifications, etc. So what they're telling you is based upon something they learned when they're growing up. Oh, just look at the food pyramid. Oh, just eat less. And so then someone like Nikki is frustrated. They're like, I don't think I'm really getting proper guidance. One of the things that I've committed myself to, and the reason why I do these webinars and do the 200 lectures that I do per year and all of the types of things that I do, is for me to begin to educate my peers, i.e. other doctors, but also educate the public. Because if the public's empowered with this knowledge, know how to seek proper care, know how to be respected, what they should be getting within that healthcare setting, that helps to empower one to get the best possible care. There are those of us that are out that are committed, dedicated to this work. I eat, live, and breathe this work. I think anyone that's around me knows that that's entirely how I feel. And I get just as angry, just as inflamed as my patients when they face some type of stigmatizing issue. Just as we get enraged and boiled about what's going on in our country right now in Kenosha, Wisconsin, and just throughout every city where we're looking at Black people being disenfranchised or hurt just by issues such as racism. Imagine how that feels when you also have excess weight and then being looked at negatively just across the board, your value and your worth being degraded just because of these outward shows that people then characterize with different value propositions. It's unacceptable. We have to do better. It's unacceptable for your doctor to be that way. And I'm sorry for those that may have experienced that in your healthcare setting. I can tell you I'm working to help undo that. Nikki and the Obesity Action Coalition are working to get the right information about how to use respectful language, people first language. There are words we don't use. We don't use the word obese. We don't say fat. Adipose is fat, which is the organ. It's actually an organ that actually has hormonal regulation. Morbid, we say morbid obesity. That's inflammatory. I can tell you that whenever I receive a patient chart, since I do see patients with severe obesity, which would be the term to utilize, that's stigmatizing. Why don't we call it morbid cancer? Why don't we call it morbid heart disease? Why don't we call it morbid diabetes? Because we have such biases that then inflict how we treat or interact with patients that struggle with excess weight. So I can keep going, but I want Nikki to be able to talk. So I'm gonna pause right there.
That was really powerful. Nikki, I'm hoping from that, especially because Fatima, she led us into the conversation alluding to stigma, right? And you were talking about body positivity and the meaning behind all of that. I'm wondering if you can help us unpack that. And specifically, actually, I'll leave that there. I'll leave that there, and then I want to come back to another question that I have. Yeah.
Well, I wanted to start off with one thing about the people first language, which was something that I did learn about through my connection to OAC. And it's interesting because it feels different to use that language. I think that it's easier for me to say like living with obesity or people with obesity, but then the first time I heard a doctor say that somebody with overweight, and I was like, what now? So the wording around it feels like, but once you get into the habit of doing that, I love that because you are a whole person. And the way that people are portrayed in the media of size is just horrible. What you tend to see is people with their heads cut off, focusing in on their midsections. They're sitting in front of a quadruple cheeseburger with an ice cream sundae on the side. I don't know anybody who eats like that. And so when I see those pictures, that's not representative of me. It was not representative of me at my largest size. It's not representative of me now. I think so far as the body positivity movement, honestly, I have two daughters of size, and I see how that movement has made a positive impact on generations. When I was younger, there weren't like bigger women, Black, white, or otherwise, sort of lifted up in the media. Bigger women were not considered beautiful or the standard of beauty. There wasn't a lot of advertisement for plus size clothing and plus size fashion and things like that. It was sort of, the message was very much, you should just take what you can get and be grateful for it. And so now you have these, you know, these activists out here, and, you know, they're wearing the bikinis, and they're, you know, making Instagram videos and things like that. And what I see in my children's generation, I have an almost 19-year-old and a 21-year-old, is that they don't think of their bodies in the same way. And so when it comes to issues of addressing obesity, I have always been a big advocate of addressing size in terms of your health. You know, when I was a kid, you know, my mother, well-meaning as she was, sort of did make those statements that assigned value to size. Like, you would be so pretty if this, or, you know, you'd have a easier time, you know, finding a husband if, you know, sort of statements. I've been very careful not to, or try my best not to pass that on to my own children. And what I see from them is that the media surrounding them gives them the message that they are people of worth and people of being, and that they can be beautiful at whatever size they are. But then the message that I come in with is that there are certain health risks associated with obesity. I want you to live the longest, fullest, you know, happiest life. I want you to be able to do all of the things that you envision doing for your life. So insofar as your health ties into that, I want us to really be having meaningful conversations about, you know, how you interact with your healthcare provider, how, you know, your behaviors tie into it, how everything ties into it, because it's so multifactorial, obesity. So I think that overall the image of bigger people living full lives is a great one, because honestly, you cannot get to being a quote unquote normal size, quote unquote normal BMI without, from a place of being obesity, without putting some work in. No matter whether you have weight loss surgery, there's a big misconception that weight loss surgery is the easy way out. I am here to tell you today it is not. I have had weight loss surgery, and I can speak on that experience as almost 13 years post-op. But, you know, it takes work to get from a place of whether you are, you know, mild, moderate, or severe obesity to a healthier weight. And the only way, it's my opinion that the only way that you get yourself through that amount of work in your head, that amount of work in your body, is to have a healthy respect for yourself, a healthy sense of yourself, and a healthy regard for wanting yourself to be healthy and live the best life you can. And that's not going to be achieved by seeing all of these negative images of bigger people. People need to see bigger people who, you know, ride a bike, who take walks, who walk their dogs, who, you know, climb a mountain, whatever it is that people want to be doing, to be able to envision themselves doing those things at any size. So in that regard, I really do appreciate the movement.
Yeah, and I completely agree with you on that. I do want to ask the audience a quick question drawing on this, and then I want to keep with you for a moment, Nikki. So for the audience, you know, we have a poll question for you. What do you think in terms of overall percentage, the prevalence of, or rather prevalence of obesity within Black women actually is, or having obesity? What is that prevalence? Is it 25%? Is it 60%? Is it 70%? Is it 40%? You make your choice, and then we'll come back to that. Okay, you can submit your question there. All right, or your answer rather. Nikki, I want to keep with you about this narrative, this messaging around just healthy at any weight, right? So we have it in our music. We have musicians and especially pop artists like Lizzo, for instance, who is singing songs about being thick, right? We have that language, that colloquial term of being thickness, right, amongst Black women is praised in a way that, to your point, a generation ago was stigmatized, right? How do we, if you can build off of what your comments, how do we really meet the language of affirmation with us, while also keeping in mind promotion of health? And using any venue, what music, art, you know, yeah, writing, all of that.
I think I come to this most strongly, like as an observer from like the music pop culture world. And let me first say, I absolutely love Lizzo. One of the things I appreciate about her in particular, and then there's a couple of other examples I'd like to highlight, is that she actually is a good example of a larger woman, a thick woman who is very open about being larger and thick, but then she's also open about, you see her like on her Instagram story, she works out a lot. She has to be able to run around the stage and sing at the same time, and she doesn't lip sync. She prides herself on not lip syncing while she's performing and dancing and things like that. So I think that's actually a good example of how, you know, obesity is related to overall health, but it's not necessarily a foregone conclusion that you're big and therefore you're on not. But then I also think of other people like Missy Elliott and Queen Latifah, who have been very open about the fact that they were comfortable in their bodies and they were comfortable with their thickness, but there came a time where their healthcare provider came to them. And I think with Missy, it was, I don't want to misspeak, but I think it might have been diabetes that she was facing. And her doctor said, you know, you have to make some changes in your life because this is affecting your overall health. And so I was so grateful to them for speaking out on it, because I know I find in my personal life, because I've had weight loss surgery, if I try to speak to any of my family and friends about improving their health and improving their eating habits, it's almost seen almost like proselytizing. They think that I'm sort of starting like the sort of timeshare pitch for them to have weight loss surgery too, which is totally not the case. But it is true that when you go through this process that I've been through of having weight loss surgery, you get a tremendous amount of education about nutrition and weight and things like that you would not automatically get from your primary care physician. When you go to see a bariatric professional, they're, you know, instilling a lot of information about how you're eating and how your activity and how your hormones and how everything works together to help determine what your personal size is. And so that puts me in a position where I have all this information that I want to share with people, really interesting stuff that I want to share with people, but you know, they automatically think, oh, well, she can get gastric bypass. So, which is totally not the case. I want for folks in my life to, you know, live overall healthier lives, because one of the messages that was given to me by my healthcare team is absolutely about how even small changes can really lead to big improvements in your quality of life and your longevity. And so that's another reason why I'm so grateful for the celebrities who speak out, the Queen Latifahs, the Missy Elliott's, even the Lizzos, because that's sort of normalizing a conversation around the effects of weight and health and things like that. But at the same time, I love the fact that, like we said, you know, with Lizzo, she's pushing the boundaries of, like, you know, stigma within the fashion industry. You have all these, you know, high-end fashion houses who are dressing her for award shows and things like that. But in the same token, you know, she's very open about, you know, she's open about being vegan. She's open about being the fact that, you know, vegan doesn't automatically equal healthy, but she's trying to be a healthy vegan. And, you know, how much activity and things that she gets to sort of bust up that stigma that just because you're a big person that you're not active, or that you're, you know, really super duper sick because of it.
Yeah, I appreciate you offering that, and I couldn't agree more. I also had the pleasure of seeing her perform at the Grammys earlier this year, and she opened up, and it was incredible. But that was what was on my mind as I was listening to her and watching her rip across the stage. And she didn't sweat, she didn't lose her breath. It was incredible. Yeah, not incredible, but it was affirming. I'll put it that way. Yeah. Fatima, I want to talk to you about some of the things you were mentioning earlier about BMI, and then also I'm wondering if you can talk to us about how instrumental you find BMI measurement to be, because I would argue that it is a problematic measurement. I think there are a number of us on the webinar who would agree. And then also talk to us about as a provider, because Nikki mentioned something really significant earlier. She said that the primary care model does not really lend itself well to really treating and having conversations about managing weight and really understanding what it means to have obesity. So how is it that you as a provider really help to make those connections with and for your patients?
Absolutely. So I think you bring up a lot of important points. First of all, like I told you at the outset, BMI just takes into account height and weight. It doesn't take into account fat status or water status. It just gives a number. And actually, if people may not be aware, but the BMI charts were actually drawn based upon the Metropolitan Life Insurance tables many years ago. What you may or may not know is that many of us were not included in those evaluations as they were trying to determine weight status, to determine whether or not you would get the life insurance policy that you wanted and how much more they would charge you. And so that is basically where BMI is derived. So I think, you know, BMI is a good population-based tool. It can kind of just group parts of the population together. But once we look at the individual that's sitting in front of me, I don't ever, and my patients can tell you, and I have thousands of them, I never give them a target weight, ever. They keep, 8 years later, they may ask me, so what am I supposed to be? And I'm like, you know, I'm not going to do that, because I don't know what they're supposed to be. Their body tells me the answers. And I really think that Nikki brought up something good, and I really want to debunk this myth that surgery is the easy way out. Absolutely, completely false. Obesity is a chronic disease. We want to use the right tool for the size of the problem. What Nikki told you at the outset is that, and tell me, Nikki, if I'm wrong, but I'm pretty good at remembering things, that at her highest, she was 360 pounds, correct? Right? She's shaking her head. Okay, just make sure I remembered that right. Which means that she had severe obesity. Once your brain gets to a certain point, the hypothalamus wants to hold on to wherever it is and wants to help you maintain that weight, whether it's low or whether it's high. And so I kind of like to think of this as like a gas tank, you guys. So think of your body as a gas tank. Maybe that's not something you thought of it as before. But if you have severe obesity, your gas tank is the size of like an army tank, like, you know, the big army tanks that are driving around, and your brain is going to do whatever it can to maintain an army tank. You're like, but I want to be an SUV. And it's like, no, I'm an army tank, right? If you're leaner, and these are some people, this is a rare phenomenon, but there are some lean people that are trying to gain weight. They want to bulk up, right? They want to get heavier, and they're facing resistance that way, because they are the size of like a little smart car. You know, the little electric smart cars? That's their gas tank. And it's just this where we are. What happens with surgical intervention, what Nikki, I don't know which surgery she has. I'm assuming a bypass. Let's just go with that. If it was 13 years ago. So that was what was the most common then. So what we do is we change the signaling between the brain and the gut. So when she had her surgery, now she eats, she bypasses the beginning part of the stomach, and the first part of the small intestine, jumps over to the part of the small intestine, and that's where her food gets processed. Well, that part that she bypassed houses a hormone called ghrelin. Ghrelin is a hormone that stimulates hunger. It is what we call an orexigenic hormone. So there are orexigenic hormones and anorexigenic hormones. This is orexigenic. When we think anorexigenic, we think anorexia, we think less food and take less storage. But it's not just about what you're eating, it's about what you store. And so the brain, when we have severe obesity, has decided I'm an army tank. And so even as we lose weight, so a lot of people come into me, they're like, oh, I've been successful. I lost 100 pounds. And I'm like, I don't care about acute loss. I care about sustainability. So the best tool that we have to treat severe obesity to get sustainable results over time is metabolic and bariatric surgery, okay? We've changed it from weight loss surgery more to metabolic and bariatric surgery because it actually changes how the brain-gut communication happens. People think it's because their stomach is smaller or the pouch is smaller. That's what's causing it. No, it's the brain-gut signaling that causes that shift that can be more sustained over time. But even for those that have surgery, which is why it's not the easy way out, once they get to their nadir, i.e. their low point for weight, the body is like, up, but I was 360. And it wants to start cruising back. Now, it may not come back to 360, but it wants to cruise, and you will have this rebound. That happens with any form of treatment, whether it's surgery, whether it's medications that I prescribe for patients, whether it's behavioral modification. You get to a point, and the body's like, oh, that's great. Let's start cruising back this way. And so we're in this constant battle between different hormones. I can't go through all of them, you guys, because you guys would be here for another 4 hours. But ghrelin is one of the important ones. And so it's important for us to recognize that, first of all, surgery is not the easy way out. It is a tool. It's about using the best tool for the size of the problem, or the right tool for the size of the problem. If someone had cancer, we wouldn't just be like, okay, just go eat less and exercise more. It may help the cancer in some way, form, or fashion, but it shows you how even in terms of how we would evaluate a person in terms of what they selected. If the person says, I have a cancer, I want it cut out, nobody would judge them. They'd be like, okay, well, she wants the cancer out. That kind of makes sense, right? It's logical. But we have these biases when people select metabolic and bariatric surgery, which is the gold standard everywhere in the world for those that have severe obesity in terms of treatment. Keeping in mind that if you're using this BMI criteria, when most people lose, they still have obesity, just a lesser degree of obesity. And it's a lifelong battle on how we're managing that. So I have patients that are now 30 years out from surgery that I care for chronically for their still obesity, or even if they've normalized their weight based upon BMI criteria or whatever. But I can tell you what I do at every single office visit is I measure waist circumference, which is a very easy thing to do. Tape measure, cheap. You don't have to go buy some fancy equipment. You don't need a fancy Apple Watch with the cute band, by the way. See that cute band? You don't need any of that. All you have to do is have a tape measure. You want to measure around the waist. And so there are things that we do know about waist circumference that actually look at metabolic health, right? For women, we want that waist circumference around, using the umbilicus as a guide, to be 35 inches or less, and for men, 40 inches or less. And men are like, oh, well, I wear size 38 pants. Well, no, they wear their pants below their umbilicus, right? So if you actually go up there, it may be 55, right? And they're like, oh, but I thought I was 38. No, that's where they wear their pants. That's sometimes the overhang that you see, they don't take that into account. They think their waist is below that, because not many patients wear their pants where Steve Urkel, if you guys remember that, where he used to wear his pants. That would be where, kind of the true waist. So I'm going to think about that. When we're thinking about the primary care model, obviously I'm a specialist, so I only care for patients that have overweight and obesity, and I care for both pediatric and adult patients. But when I'm talking with my primary care colleagues, a lot of it is about educating them. And I can tell you that we're doing larger scale implementations of things to help primary care doctors be better at being on the front line. So I'm overseeing the inaugural committee on obesity for the American College of Physicians, which is all of internal medicine. I can tell you that right now we're in the trenches of developing materials that will be then launched out to all internists that are members. We have over 140,000 members of the American College of Physicians, but not just ACP, which is internal medicine, which are doctors for adults. There is a coalition of different groups, including the American Academy of Family Physicians, the American College of Physicians, endocrinologists, et cetera, where we're developing a toolkit that can go out to primary care physicians. We actually just finished up the last few touches on it a couple of weeks ago, which guides you on how to have the right conversation that's non-inflammatory, non-accusatory, and it's actually helpful in the primary care setting. What Nikki told you was that when she went into this kind of specialized care, she learned a lot. But before then, it doesn't sound like she was getting really any useful information. And so we need to do a better job, because if you're getting bad information at the start or not getting any information, then how are you even making it over to that team if you need that level of care that's much more intricate and detailed? How are you even making it there? And then what do you think about, what are you anticipating about what that conversation will be like? What I can tell you, taking care of both kids and adults, and so I would say my patients range from the age of 2 to about 88. I have patients that are in their 70s that come in for their first appointment that are crying about something that their pediatrician said to them about their weight, what would now be like 65 years ago, right? Like, they remember, they internalize, their doctor's relationship with them is extremely important. So if you remember your doctor saying to you at 5 something very bad about your weight, that has set up your entire interaction with the medical system for the rest of your life. And at 72, you're sitting there in your appointment with me, and I'm hearing it as if it was a fresh, raw thing that's happened, but it's had such meaningful impact. So we have to be very cautious about how those interactions that we have across the age spectrum really affect how patients feel, how people feel when they're trying to navigate the system that's supposed to help them, but often feels like it's not out to help them. It feels like it's there to just create more stress strain, more devaluation, and that's problematic. So like, we have to do better, and I can tell you that we're trying. I'm trying to help on the primary care side of things, recognizing that as a specialist, that I'm in somewhat of a different world. Once persons get to me, they know what we're going to address, right? They know what our topic of conversation. I work at the weight center. It's not unclear what our conversation will be related to. But on the primary care side of things, we have to do a better job. And I still think that, even as obesity medicine physicians, we can always be working to improve the care that we're delivering.
I do want to point out sort of a difference in experience between me and my kids, which is pretty encouraging, which is that my youngest daughter, she is 18 going on 19. And one of the things that they don't tell you, they have all these what to expect when they're expecting and what to expect when they're 1 and 2 and whatever. Nobody's really written a definitive book on transitioning your kid from adolescence to adulthood. And so I knew that at some point my daughter should stop.
We have to do next. We have to do that next. In my spare time, yes. I'm not writing all the other things.
Please do. Thank you. But so I knew that we should be transitioning from her pediatrician to a primary care physician. Her pediatrician did see patients up until age, I think 21, but it was just got really awkward sitting in the waiting room with like newborns and cartoons on the walls and things like that. So we switched doctors, and I decided to use a resource that the OEC developed called Obesity Care Providers. It can be found at obesitycareproviders.com. And what it is it's a website that is a clearinghouse where you put in like your zip code, and you can find obesity care providers. You can find like bariatric surgeons, primary care physicians, people who have the distinction of being a bariatrician, which I would ask you to probably go into more detail because I'd get it wrong to explain exactly what a bariatrician is, but nurse practitioners, dietitians, the whole gamut. And so I said, well, let me give this a whirl. And so I typed our zip code into there, and I found a doctor who was relatively close to us. I knew you can filter it for certain things. So I figured that my daughter would be more comfortable with a woman doctor. So we chose a woman doctor, and I knew that, we ride public transportation, so we didn't want it to be too far away. So I, just said within 5 miles, and we found a doctor at a nearby hospital system, and the differences were tremendous. When your kids get to that age, they get to decide whether or not they go back into the examination room with them. So she opted to go into the examination room without me. I'm in the waiting room, nervous mom sitting there. And I expected that the actual FaceTime with the doctor would be maybe 20, 25 minutes. That was pretty standard for doctors' visits up to that point. So you can imagine 45, 50 minutes later, I was very nervous about what was going on back there in the doctor's office. But when she came out, she was smiling, and the doctor actually came out and explained a few of the follow-up things to me as her mom, knowing that 18-year-olds probably need their mom's help following through with things. But then as I was listening to my daughter describe the doctor's visit, it was, she told her, my daughter has things like, she suffers from migraines occasionally. She does, have a weight issue. She does, have all of these other things going on. And the doctor talked to her about those things separately, made plans separately. She ordered tests separately. It wasn't automatically, oh, well, you need to lose some weight. They did talk about her weight, but that wasn't the first thing that they talked about. And it wasn't the thing that they talked about at length. Her doctor explained that, I want to get all of these other issues under control because it sounds like they're causing a day-to-day, discomfort for her. And we get those under control, and we'll continue to work on the weight thing. And it sounds like, to me, from the outside, hearing from my daughter, that she did talk through a lot of what might be going on with her body with her. That had never happened to me in a doctor's appointment. And even with my doctor I have now, who I actually think is pretty good and who is actually, he's amenable to working with my bariatric surgeon even 13 years later to understand how some of my body works. That level of conversation had never happened to me in a doctor's office. So it really does make a difference. And so on the patient side, I would encourage folks that if you need to find a physician that has experience working with people with obesity, to check out that obesitycareproviders.com, because that's a good starting point of somebody who, at least when you're walking through the door, has some form of training in working with people of size. And then, that initial sort of knowledge just makes it so much easier to work as a team with them to work through some of your issues.
Yeah, thank you both for really laying that out. There was some rich information, and I wish we had more time to even dig into that, but I do want to pivot a little bit. First, I want to go back to the poll question about prevalence of obesity. And it looks like most people have selected the correct answer, which is 60%. In terms of prevalence of obesity among women who are Black here in the U.S. And honestly, I would love to see, maybe at some point we can have a more global conversation, because Fatima, to your earlier point about really understanding what goes on around the world with respect to obesity, there's quite a lot in common between us here and abroad. And so speaking of around the world, I do want to pivot a little and talk about another pandemic and overlay the conversation of obesity with the conversation of COVID-19. And last week, we had a conversation with three really very significant people to bring us a conversation around food security and food insecurity. So we had with us the CEO of Feeding America, Claire Babineaux-Fontenot. She came on. We also had with us the deputy chief of staff for Congresswoman Marsha Fudge, Eon Garrison. And then we also had with us Michelin star chef and owner of Masseria restaurant in DC, chef Nick Stefanelli. And between the three of them, we talked about what food insecurity looks like. We didn't so much get into the conversation of how on one spectrum, food security and food insecurity may manifest itself as obesity, right? So I want us to really break into that and then help us to understand how the pandemic of obesity overlaid with the pandemic of COVID-19 is really impacting our communities here. And we may not be able to speak to the global point, but I do want us to talk about that. Yeah.
Okay, absolutely. I'm typing. I'm doing multiple things, but I'm typing to you guys. So if you're seeing my answers come up as me as asking me those questions. So I think you bring up an extremely important point. I think you brought up two different key issues that we should talk about. COVID-19 and its relationship to obesity and the severity of COVID-19 and morbidity and mortality associated with it. So what we started to note when really the obesity or the COVID-19 pandemic, because I would say the obesity pandemic has already been here. We got a new pandemic that showed up. And let's say we really start to really notice it, right? March was when we really started to notice what was going on. If you had looked at the CDC website, pretty early on, they decided that a risk factor for COVID-19 in terms of morbidity, i.e. sickness, mortality, death, was obesity, but they specifically stated those that had severe obesity. But as time continued to move on, they found that obesity across the spectrum, of course, of this BMI, that they were noticing differences. What I was noticing is watching the news, and CNN tends to be my station of choice. I would notice that they would say, oh, this patient has no underlying conditions, they're dying. But I would notice, at least visually, that they did have obesity, but people don't think of that as a disease, right? Like that's just the way you look. And so they'd be like, well, they have no underlying conditions. And I'm like, well, I was noticing this. And as a doctor, what we were seeing at my hospital here at Mass General, where we had as many as 359 inpatients with COVID, that we were seeing a lot of patients with obesity being admitted. And so you could see the story was kind of playing out as people were kind of jumping on the research bandwagon to figure out what to do. So what I want to talk about is obesity often is characterized by inflammation. There's inflammation associated with it. So if we were to measure inflammatory markers in the body, like IL-1, IL-6, TNF-alpha, MCP-1, just to name a few, we would often see those elevated in persons that have obesity. Not universally, but often see that elevation. When we're dealing with this viral pathogen of COVID-19, or what we call SARS-CoV-2 to be the most specific about what it is that it's characterized by inflammation, is characterized by a release of chemokines and cytokines. And this collision of these inflammatory markers appear to worsen prognosis when someone is faced with COVID-19. So that's one end of the spectrum, and we're learning more and more each day. I'm leading the efforts here for our health system, looking at obesity and its impact on patients that have had COVID that have shown up in our doors. I think our story will be slightly different than the story that we've had to tell. I can't kind of give away what we're going to see, but the story will lend itself to a little bit more information, I think, based upon what we're seeing from the data of all of our patients. That's number one. Food insecurity. Let's talk about this food insecurity. Food insecurity is not knowing whether you will have access to food, maybe at the next meal. And when patients have food insecurity, what we've seen prior to COVID, because we haven't really analyzed it well in the midst of the COVID, is about 35% of the patients that have food insecurity also have obesity. Because it's not just about getting the food, it's about getting access to high quality food. When you're going to something like a food bank or a food pantry, you're at the beck and call of whatever has been donated. What's donated often is processed. That's easier to store. And so we know that the more processed the food is, the worse it is for our metabolic health. And so we do see this overlay of food insecurity and obesity, and that's been a common theme, which I think will just worsen in the midst of this COVID-19 pandemic, where we've had so much job loss and things of that sort, where people that have not had to rely on assistance for securing food are now having to do that on top of those individuals that already struggled with that. I can tell you, my parents, growing up, my parents have always overseen a food pantry at my church, and I oversaw the clothing bank all through high school, but also worked with the food pantry. And so I get to see them, and they, with their masks, donning their masks, still going in Atlanta, which is where I was born and raised, every single week, making sure they've secured the food for the hundreds of families that come into them every week. at their church, Allen Temple AME Church in Atlanta. Seeing their dedication, their commitment to this for the last 35 years has been quite amazing, and seeing them navigate this as Black folk who are over the age of 65 in Atlanta, Georgia, has been terrifying, I can tell you, especially when I look at the fact that they've lost 10 of their friends to COVID-19. I can tell you that I know that they're doing it from the bottom of their heart, and I'm thankful that they're using safe practices to make sure that their community gets access, at least some of their community is getting access to some of the things they need, and hopefully healthy foods and things of that sort, but not always the case. So there's those two things. I want to address a few key things really quickly. I'm going to go through really fast and talk fast. Hopefully you guys can keep up with me. One of the persons asked me about the use of anti-obesity medications. I do believe in the use of anti-obesity medications. They are underutilized. I do want to give two major statistics with regards to both bariatric surgery and with regards to medication. Only about 1% of the persons in the United States who meet the criteria for metabolic and bariatric surgery actually get surgery. And when you control for socioeconomic status, et cetera, Blacks are the least likely to get access to therapy. With regards to medication, only 2% of patients that meet criteria for the use of anti-obesity medications, which are medications to treat obesity, which do need to be used chronically, because we're treating a chronic disease, much like if we were treating high blood pressure and you keep the medicine on. If you take away the medicine, the blood pressure elevation goes back. So it is chronic use of these medications, underutilized, only 2% of the population. What can we be doing at a big societal level? There's the Treat and Reduce Obesity Act, which we've been trying to get through the House and Senate for years now. It has great bipartisan support. I think it's going to need to come under a larger omnibus bill to actually make it through the House and the Senate, like some type of must-pass legislation to get it through. But what the act basically,
or even the next COVID-19 bill, if that
right, yes, right, a big,
exactly.
a must-pass legislation. So
that's right. That's right.
So basically what it covers is behavioral care for obesity. Right now, if you were to go see a dietitian and you have a diagnosis of diabetes, you get your visit covered. But if you have obesity, it's not covered. You're paying out of pocket. We recognize diabetes as a disease. It gets a lot of good play, but obesity not. So we wait until you get diabetes and now we give you a dietitian. It's completely backwards. It makes no sense. So basically it's coverage for behavioral therapy, much like a dietitian, and coverage, more adequate coverage for anti-obesity medications. Another question that was asked was, what about this kind of overlay of diabetes, and what if a patient has diabetes and obesity? Actually, the treatment often for those patients is a little bit easier for the reason I just brought up. People recognize diabetes as a disease, and even if we're looking at anti-obesity medications, for example, they are often approved for diabetes 3, 4, 7 years before they get approved for obesity. They're usually approved at a higher dose for obesity, but why is it taking that much longer for the exact same compound to get approved? Because people don't really recognize it as a disease. And it was only around 2012 that the FDA began to do a better job of approving anti-obesity medications, but it still lags dramatically behind diabetes. So if a patient has diabetes and obesity, I can use all the medications that are covered by Medicaid, by Medicare, by their private insurance for diabetes, not being covered for obesity, even when, covered, unless it's private insurer. Private insurance some of them will cover some of those anti-obesity medications. So a little bit easier for me to treat, easier for me to get something like a metabolic and bariatric surgery approved for consideration. So it's not necessarily easier for the patient. I would say that they still have, they're grappling with two major diseases. But in terms of me delivering care, the delivery of care is indeed, I would say, slightly easier. Not slightly, actually significantly easier.
That's good to know. Yeah, so much great information there. And I hope people, especially because some of those questions were posted in the chat, that you got what you needed from Dr. Fatima Cody, Stanford's answers there. If you want to know more, we do have some posts in the chat that you can follow. Nikki, I want to bring you into this too. Same question. We're talking about obesity as a pandemic, we're talking about COVID-19 overlaying that. How is it that we are really, especially amongst the patient advocates, what's the message? What are some of the things that you all are dealing with in the Obesity Action Network?
Most of it is about getting accurate information out there. You know, when message lines come out about correlations between things, the media can sometimes run wild with it. The big thing is just making sure people understand what the information all really means and how to best protect themselves. I think that one of the biggest things is that, you know, everybody has such mixed opinions on COVID in general, you know, wear a mask, not wear a mask, social distance, not to social distance, and just really understanding that there's several levels of risk factors. There's some that have been raised up more than others, obviously age and, you know, having pre-existing conditions. But like Dr. Stanford said, you know, the obesity isn't often sort of thrown in there with those because it's sort of a touchy subject.
Nikki, it seems we lost you a little bit. You were saying such good things.
Yeah, I think she froze.
She did freeze. Let's give it a couple seconds. Once she comes back on, we're going to jump right back into it. Let's go to another poll question really quickly, just as we're waiting, and we have.
Oh, wait.
Oh, there she is! Yay! All right.
Yeah, I had to turn off my camera. I'm sorry. But yeah, no, basically real quick, because I know we're running out of time, is that just basically saying that, you know, with obesity, it is a risk factor and that we need to normalize the conversation around that. A lot of people, you know, have this association between obesity and your value as a human being or your worth as a human being. It really is a medical issue. It is a disease. I am going on 5-year breast cancer survivor myself, and I don't have any qualms talking out loud about the fact that I am a survivor of breast cancer or what I had to do for my treatment. Whereas with obesity, there's like all of this, you know, sort of shyness about talking about it. We need to normalize that conversation, bring it into the broader spectrum, make people know that, you know, it does not have any bearing on who you are as a person, the quality of your character if you have obesity, that it is a disease. A lot of people are resistant to that idea. OAC supports that idea and wants folks to talk about it. So that's been a lot of the basis of what the organization does. We have a lot of really engaged members. We try to focus on education and support, but then also reiterating those messages. And I saw somebody in the chat ask about the Treat and Reduce Obesity Act, and there is information on obesityaction.org about that and how, and in our Action Center, you can actually take action and support the legislation with your own elected officials.
Well, ladies, thank you so very much. I just want to summarize some of the things that you mentioned and then give you just maybe 30 seconds with final words. But we talked about obesity, our person-first language, right? So having obesity and really clarifying that it is a disease, that we should make certain that we're valuing and qualifying from a medical perspective, right? We also talked about BMI being a problematic descriptor or metric rather of obesity, and the ways in which messaging and in terms of what one can do individually and how one can be empowered through understanding their own health and wellness. And we mostly just decided that it is a population metric, and that's how it should be deemed. When we're talking about obesity as an expression of, or food insecurity potentially expressing itself as obesity, mirrored against the backdrop of COVID-19, completely exacerbates something that's been ongoing. That was also another point that you all made. We talked about stigma. We talked about body positivity, this idea of making certain that we honor ourselves and our bodies, but also pushing toward being our healthiest and best selves. They are not mutually exclusive concepts. We also talked about addressing, you know, whether or not you can address or really troubling the idea that the primary care model may not lend itself well toward really addressing the disease of obesity in the long term. And then we also talked about what we can be doing outside of the clinical setting from a political perspective, from a policy perspective. So really understanding what goes on in Congress. One of the things that both our speakers today brought up today has to do with Treat Obesity Act. It's both in the House and the Senate. definitely call your members of Congress, push for support in that. We're coming up on 3 more months in Congress, and really it's like less than that, because the month of December is, well, that's that. But so I thank you so very much, Nikki, Massey. I thank you so very much, Fatima, Cody, Stanford. Closing words from you all before I turn it over to Brandon.
Well, I just want to thank each of you that have taken time out of your schedule to listen in about this extremely important topic, a topic that's paramount. Obesity is by far the most prominent, the largest chronic disease within our community. We don't take ownership of really ensuring that our care is optimized. And I think you've learned some valuable tools that you can utilize, both from the patient perspective, listening to Nikki's perspective, for myself from the physician and scientist perspective. There's quite a few things that are in the chat that if you guys want to take a look at, lectures, tools, resources, books. I've written a book called Facing Overweight and Obesity, a complete guide for children and adults, which is available for you to really dig into almost 300 pages of this information. So there's a lot that's out there. There's a lot of us that are trying to do this work. And I would just say continue to seek knowledge, and we'll continue to really kind of push the agenda.
I echo a lot of what you said. I love this conversation. I love the fact that it's happening. I was not very aware of NMQF before this, but I am now. I am now following on all social channels. I want to be a part of the conversation. I'm very interested in the food insecurity conversation, so I'm going to go and check that out on my own time. But thank you. Just thank you for having this forum, because I feel like this is, talking about things gives them power. I am, by trade, a communicator and a marketer. So I know the power of just simply talking about things, and having us all here listening to this information, talking about it openly and asking questions in a place where we feel, safe and comfortable and have the expert knowledge to follow up with it is just an awesome thing. And I commend you all for what you do. I commend you, Dr. Stanford. I look forward to getting to know you and your work better. And I just really appreciate being given the chance to be a part of this conversation.
Well, again, we thank you both. We thank the audience, and we're looking forward to just continuing conversations as we move forward next week. And once again, I'm Mia Keys with the American Medical Association Center for Health Equity. Really excited that we had this time today to sit and chat. I turn it back over to Brandon Garrett.
For all your expert advice. I noticed you just had your words made everybody want to participate, because they have, if I look at the comment sections and the questions, we had, 50 questions in there, and thank you guys for addressing them and also getting everybody excited and wanting to participate. Again, you can, we always have these events on every Friday at noon, so if you just kind of click the link, we'll be talking about something very educational and important. And just also want to give a quick plug that our big annual summit on health disparities that we usually have in April is gone virtual, and we'll have that in October, so you'll get more information about that on Monday. And with that, I hope everyone has a great day, and I'll talk to you soon. Bye, folks.